Hi, this will be your discussion on the disorders of cerebral blood flow. Okay, here we will be talking about stroke, one of the easiest topic that we have in neurologic nursing. Okay, so class disorders of cerebral blood flow. Okay, so another term for your stroke is your cerebrovascular accident. So when you encounter the term CVA or cerebrovascular accident, we are referring to stroke. Now, so when I say stroke, it is characterized by a disruption in the normal blood supply to your brain, which could occur suddenly and would produce focal neurologic deficits. So you highlight disruption in the normal blood supply to the brain. The problem in your stroke class is that there is no adequate supply of blood going towards your brain tissue. In other words, if your heart is experiencing myocardial infarction, your brain would be experiencing your stroke. There are several causes of stroke. One of the major that we can remember from our discussion in cardiology nursing will be your atherosclerosis. So take note that your atherosclerosis is characterized by the fatty deposits on the arterial walls. So class, when these deposits would clog up, wherein there will be clot formation, and then the clot would travel towards your brain, that would result to stroke. Other risk factors are your hypertension, especially poorly controlled hypertension. Plus, your hypertension, once there is super high blood pressure, might result to rupture of blood vessels in your brain. Diabetes mellitus. Okay, your diabetes mellitus or poorly controlled diabetes mellitus would also increase the risk for your atherosclerosis, hence increasing the risk for clotting. You also have your sickle cell disease. Recall from your maternal and child nursing that your sickle cell disease is characterized by the sickling of your cells. In other words, instead of the regularly shaped concave red blood cells, your sickle cells would look like C-shaped cells, and then they have the tendency to clump and then to coagulate with one another. Okay, so there will be clumping of your red blood cells. This clumping of your red blood cells may increase the formation of your clot that later on will result to a thrombi and then later on may travel as an emboli, increasing the risk again for stroke. Okay, substance abuse. Your substance abuse may result to vasoconstriction, which would decrease the blood flow going towards your brain. And then class, it may also result to vasodilation. Too much vasodilation would still increase your ICP, okay, because of too much blood going towards your brain. And then atherosclerosis, as I have previously touched. Then you have your previous history of CVA. It is known, class, that patient who had previous history of stroke will be at increased risk of stroke, okay, in the incoming years. Okay, usually, class, there will be recurrence of stroke, especially if the patient is not complying with their maintenance. Obesity. Okay, your sedentary lifestyle and obesity are among the modifiable factors related to stroke. Then also your hyperlipidemia. Okay, hyperlipidemia would still connect your atherosclerosis. Then we also have your cardiac disease, specifically your dysrhythmias. Among the dysrhythmias, it will be your atrial fibrillation that will be increasing the risk for ischemic stroke. Recall that in atrial fibrillation, the heart is not able to pump effectively in such a way that part of the blood that instead would coming out of the heart would stay in the heart. Now, with the blood staying in the heart, the tendency is that there will be clot formation. With the formation, class, of clot, okay, with the formation of your clot, the tendency is for this clot to travel towards your brain through your carotid arteries, okay, having your thrombus going towards being an emboli. And this emboli could block the major arteries of your brain that would lead to ischemic stroke. So again, the major risk factor for cardiac disease is your atrial fibrillation. So class, for your atrial fibrillation, this may lead to emboli formation, which would later on block a major blood vessel going towards your brain. Now, you also have your polycythemia. Class, when I say polycythemia, recall that this is an increase in the production of your red blood cells. Okay, the common type of your polycythemia is referred to as polycythemia vera. So class, the bone marrow would continuously produce red blood cells even though the body does not need red blood cells. Okay, so class, that results to the thickening, quote unquote, of your blood, okay, thickening of the serum, increased concentration of the serum, and because of that, there will be at high risk for clot formation, okay, among your patients with polycythemia. Okay, clotting is also increased among patients who use oral contraceptives. Okay, for those with periodontal disease, the risk factor is also increased, especially for those also classed with chronic inflammatory disorders. Your chronic inflammatory disorders, such as your systemic lupus erythematosus and then your RA or your rheumatoid arthritis, would increase also class the risk of clot formation. Okay, other than that, they would cause inflammation on other organs that would later on still lead to clot formation. And then, of course, you are smoking. Okay, smoking class would contain nicotine, and we know the effects of nicotine, okay, increasing the effects for your or possibility of having a stroke. Now, we have the term transient ischemic attack. Class, when we talk about transient ischemic attack, in layman's term, this is what we usually refer to as your mild stroke. Okay, we oftentimes refer to that as your mild stroke. When I say TIA or transient ischemic attack, it is a brief period of localized ischemia wherein the deficits would be lasting for less than 24 hours. Okay, the deficit would only be for less than 24 hours. There will be inflammatory artery disorders class as one of the cause of your TIA. Your sickle cell anemia could also cause your TIA. Atherosclerotic changes in the cerebral vessels along with your thrombosis and emboli could also cause your TIA. Okay, another cause is your subclavian steal syndrome. Now, okay, the characteristic difference of your TIA, or difference I mean of your TIA compared to ischemic and hemorrhagic stroke is that your TIA would only last for 24 hours. But if we are seeing patients whom the signs and symptoms has exceeded 24 hours, we are already considering an occurrence of an actual stroke. Despite the fact class that your TIA is only referred to as mild stroke, it still increases your risk for the hemorrhagic and ischemic stroke. Okay, in fact, it could double your risk for the occurrence of stroke. Now, oftentimes, these are patients who would present in the ER and then would say that they had an incident of fall, and then they are not sure why did they fall down. They would say that they did not trip, okay, but instead, class, they just fell down. Okay, so that fall may be related to the weakness of the extremities. And then they would present in the ER well, maybe with a little bruise because of the fall, but generally they will be well. Neurologically, they will be well. Okay, plus that may be already a transient ischemic attack. However, we could not ensure that this is a transient ischemic attack unless we will observe the patient for the next 24 hours. Now, let's discuss about your subclavian steal syndrome. For us to understand your subclavian steal syndrome, let us be reminded by the anatomy. So recall that this is your left ventricle and this will be your aorta. Plus from your aorta branches what we refer to as your subclavian artery. Now, class, from your subclavian artery here, okay, or from your aorta here, okay, one branch is going to the subclavian, the other is going towards your vertebral artery. Recall that your vertebral artery is among the blood vessels that would supply blood going towards your brain. If you can recall this structure class, this is already your circle of Willis. Okay, circle of Willis. Now, your SSS or subclavian steal syndrome is a vascular phenomenon in which, for example, class, a stenosis on the proximal subclavian artery would cause a retrograde flow in the vertebral artery away from the brainstem. Okay, what do you mean by that? Or what do I mean by that, class? Okay, if this is the normal blood flow, supposedly from the aorta, it would go, part of the blood would go to the subclavian, part of the blood would go towards the vertebral artery. But what happens, class, in your subclavian steal syndrome is that if there is subclavian stenosis, okay, or meaning narrowing of your subclavian artery, the tendency, class, is for the vertebral artery to push blood away from the brainstem. Look at this. There is stenosis on this part. Okay, so, class, since there is stenosis, there is only minimal blood passing through this part of your subclavian artery. What happens? From the other side, class, the vertebral artery would be pumping blood also going towards the upper brain, okay, or the parts of your brain. However, in subclavian steal syndrome, what happens is that the left, for example, or the right, okay, the right vertebral artery would pump blood, and then this blood, class, tend to go to the opposite vertebral artery, and then would go towards your subclavian artery. Okay, in other words, class, we are decreasing, your subclavian steal syndrome is decreasing the blood supply going towards your brain. Okay, referring to that condition as your vertebrovascular insufficiency. In other words, class, there is insufficiency of your blood supply going towards the base part of your brain due to the problem in your vertebral artery. Hence, you have the term vertebrovascular insufficiency. Okay, so this is your subclavian steal syndrome. Okay, so this is another illustration of your subclavian steal syndrome. Okay, so class, if you can notice, instead of the two vertebral arteries, okay, having the blood going towards the circle of Willis, what happens is that the blood, okay, is going towards the subclavian artery. Okay. Now, these are the clinical and urologic manifestations of your stroke. There could be contralateral numbness or weakness of the hand, forearm, and corner of the mouth, and that is related to the middle artery involvement. Okay? Aphasia class is related to ischemia of the left hemisphere. Then your visual disturbances would of course involve your posterior cerebral artery. Okay, because your posterior cerebral artery will be the one that will be supplying the blood going towards your occipital area. Furthermore, okay, we need to be reminded that there are two major categories of stroke. One is hemorrhagic, and then the other one is ischemic. Okay, as the term implies, class, hemorrhagic, there is bleeding. Okay, for ischemic class, there is decrease of oxygen. Another name for your ischemic stroke is also known as thrombotic stroke, because one of the major reasons for your ischemic stroke, if not all, will be a thrombus. Okay, it will be a thrombus, okay, becoming an emboli, and then it travel to other parts of the body. Okay, so that's the difference between your hemorrhagic and ischemic or thrombotic stroke. Now, let's talk about your ischemic stroke. So ischemia, when I say ischemia class, there is a decrease of oxygen supply going towards your brain. Okay, and this decrease on the oxygen supply in relation to the demand is related class to the stenosis. Okay, it is related to the stenosis of your blood vessels. Or there may be an emboli which clog up on a major blood vessel of the brain. Now, when I talk about ischemic stroke, there is loss of function resulting from disruption of blood supply to the brain. Again, the problem is disrupted blood supply going towards the brain. This kind of stroke is divided into five. So you have your large artery thrombotic stroke, your small penetrating artery thrombotic stroke, then you have your cardiogenic stroke, and then you also have your cryptogenic stroke. Talking about them one by one. So class, this is our large artery thrombotic stroke. So class, your large artery thrombotic stroke is usually caused by an atherosclerotic plaque. Okay, as you can see on the image on the left class, so these are your atherosclerotic plaque that is being deposited on the arterial walls. So what happens here in your large artery thrombotic stroke is that class, because of the fat deposition or atherosclerotic plaques here, the tendency is for your clots to attach. The tendency is for the platelet to aggregate on that side. Because of that aggregation class, thrombus formation is very likely. Okay, so that's what happens in your large artery thrombotic stroke. Now, in your small penetrating artery thrombotic stroke, okay, this is a part or type of stroke wherein one or more vessels, okay, are being damaged. And the most common type of which is your ischemic stroke. Then, class, under your ischemic stroke, you would have the term lacunar stroke. Okay, so meaning these are small strokes. Okay, now you also have your cardiogenic or embolic stroke. So class, when I say cardiogenic, this is caused by a thrombus or a clamp through the cerebral vessels that are lodged in a vessel that may be narrow. So again, the reason for this are cardiac dysrhythmias, and particularly we are talking about your atrial fibrillation. The frequent site class for your cardiogenic stroke are the bifurcation of vessels of the carotid and middle cerebral arteries. Okay, so when I say cardiogenic, of course, we're talking here about terms. So class cardiogenic, okay, you have your cardiac dysrhythmia, and then you have your atrial fibrillation, to be more specific. Okay, now, the onset class of your cardiogenic stroke tends to be sudden, and then immediate deficits may occur. Embolus class may break into smaller fragments and absorbed by the body. Okay, there is a tendency class for the embolus to break down, and then this could be reabsorbed by the body. Okay, so making the symptoms disappear in hours to a few days. When this embolus is not absorbed class or not broken down, and then if the symptoms would persist, okay, even if it is absorbed class, weakness of the vessel wall would increase still the potential for cerebral hemorrhage. Okay, so it would still increase the potential for cerebral hemorrhage due to the weakened vessel wall. Other causes of stroke are stated on this slide. So you have your illicit drug use. Plus, your illicit drug use may over increase the flow of blood going towards the brain, okay, which may result to cerebral vasodilation, increasing the intracranial pressure. Coagulopathies. Coagulopathies are blood clotting problems that would increase the risk for bleeding. Migraine also. Severe cases of migraine may lead to stroke. Recall that in your migraine, you have your vasodilation. Then when I talk about spontaneous dissection of your carotid and vertebral arteries, recall that your carotid and vertebral arteries would supply blood to your brain. Plus, when I talk about spontaneous dissection, this may be rupture of the arteries. Okay, then cryptogenic stroke class are stroke with unknown etiology. Okay, the term is cryptogenic. Now, what happens in your stroke? Once there is disruption class in your cerebral blood flow, ischemia would occur. And because of that, because of the ischemia and the disruption on cerebral blood flow, cell membrane dysfunction would happen. Once class there is cell membrane dysfunction, there will be anaerobic metabolism. Okay, because of the anaerobic metabolism, it would result to the production of your lactic acid and hydrogen ions. Okay, class, other than that, because of cell membrane dysfunction, there will be an increase of your calcium and glutamate. Because of this, there will be a failure of your sodium-potassium pump. Okay, recall that your sodium and potassium pump are important to ensure the movement of your muscles, particularly your cardiac muscles. Now, this will be aggravated and there will be a continuous increase of your calcium and glutamate. Okay? Added to that class, this increase of calcium and glutamate will be leading towards your vasoconstriction. If we will follow this sequelae here, okay, lactic acid plus hydrogen and hydrogen ions would result to your metabolic acidosis, still leading towards the problem vasoconstriction. These two factors combined would lead to a lot of free radicals. And the increase of your free radicals class would result to an enlarged area of infarction. The enlarged area of infarction may result to injury and cell death. Okay, for that reason, class, when your patient has ischemic stroke, okay, you're increasing the risk for cell death. And then, once this cell death class has occurred, the tendency is that if it is not prevented or if interventions are not done to the patient, the tendency is that the area of necrosis will be spreading. Okay, the area of necrosis will spread. Now, what are the most common location of your thrombi? So you have your internal carotid artery, you also have your vertebral artery, and then the junction of your vertebral and basilar artery. Okay, so these are the common locations of your thrombi. Okay, if you would look at here, your internal carotid artery is located here, class. And then your vertebral arteries are located here. Okay, that's why it's referred to as vertebral arteries because notice their location, okay, in relation to our vertebrae. And then you have the junction of your vertebral and your basilar artery. Okay, so class, imagine if the block will be on the vertebral arteries, okay, it will be a lot of blood supply that will be affected. Although we still have the circle of Willis that would offer a contralateral, okay, that would offer a contralateral circulation, okay, going towards your brain. However, this may not be last for long, or this may not last for long, I mean. Now, that's for your overview of your ischemic stroke. Yes. Okay. Then we have your hemorrhagic stroke. Okay, let's talk about your hemorrhagic stroke. Class, in your hemorrhagic stroke, this term implies hemorrhage, so there is bleeding. Okay, there is bleeding. Now, in your hemorrhagic stroke class, this could be caused by your intracranial or subarachnoid hemorrhage. Okay, class, it is commonly occurring during activity, and it is considered to be the most fatal of all types of your stroke. Okay, so this could be caused by your aneurysm. This could be caused by a sudden increase in the blood pressure, leading towards rupture of your blood vessels, resulting to hemorrhagic stroke. Now, what are the possible causes? Uncontrolled hypertension is one. Okay, ruptured intracranial aneurysms is one. Embolic CVA could also be. Okay, you might be wondering, oh, we're talking about emboli, and emboli I thought would only be affecting for ischemic stroke. Okay, class, it may aggravate also your hemorrhagic stroke. Then we have your cerebral amyloid angiopathy. Class, when I talk about your cerebral amyloid angiopathy or your CAA, it is a condition in which the proteins, okay, referred to as amyloid, would build up on the walls of the arteries of the brain. Okay, so class, the amyloid are getting stuck, okay, on the brain. Now, what is this amyloid class, no, or your CAA? So class, they would increase the risk of stroke caused by bleeding and even your dementia. Okay, so the build-up of your amyloid would increase the risk for dementia. Then you have your arteriovenous malformation. Then we also have your intracranial neoplasm. Okay, so class your neoplasm or neoplasia, okay, would usually be related to, for example, growth of tumors. Okay, this may result to compression of the blood vessels and possibly rupture. Then, anticoagulant therapy. Okay, recall that for your hemorrhagic stroke, our main problem is hemorrhage. Okay, so class, the reason for this may be is related to the increase of the use of your anticoagulants. Okay, examples of your anticoagulants would involve, okay, you have your heparin, you have your warfarin, you also have your aspirin, and then you have your clopidogrel. Okay, these are antiplatelets, these are anticoagulants, which may still increase the risk for bleeding. Okay, so if your patient class is at risk for having hemorrhagic stroke, you should appraise them, okay, by using against your anticoagulant, or let them talk to their medical professional so that they could be helped. Okay, your amphetamine class could also be a cause of your stroke. Now, the pathophysiology. In your hemorrhagic stroke, what happened is that there is rupture of the blood vessels, and then the blood would enter the brain tissue and the ventricle. Because of this, there will be compression of tissues, and the result of the compression of your tissues is vasospasm and then cerebral edema. Okay, so it's just bleeding resulting towards compression, and then compression will become vasospasm and cerebral edema. Okay, so this needs to be addressed, or else class the sequelae will continue. Now, once class the blood in the ventricles or subarachnoid space is there, okay, it would irritate the meninges and the brain tissues. This irritation to the meninges in the brain tissue would result to an inflammatory reaction. The inflammatory reaction class would impair the absorption and circulation of your CSF. Okay, so as you can see, there are several areas wherein the hemorrhage could attack our brain. Now, other than that, the continued hemorrhage would cause pressure on the brain, increasing your ICP. That's why class, if a major artery has ruptured, okay, the tendency is that the patient will just continue to deteriorate. Okay, so there will be an increase of your ICP. And then if not addressed, would result to coma and death. Okay, that's how quick your hemorrhagic stroke could be. Okay, that's why you need to immediately assess your patient. Next. Okay, so you have the following manifestations or changes in level of consciousness. So these may be applicable for both your ischemic and hemorrhagic stroke. Now, okay, class, your patient may manifest with hemiplegia. So when I say hemiplegia, there is paralysis on one side of the body. Your patient may have hemiparesis, which is weakness on one side of the body or both. Your patient may have flaccidity. So class, your flaccidity is the absence of muscle tone. Then you have your spasticity. So class, what happens in your spasticity is that there is increased resistance, okay, to stretching. And this resistance class is also increasing. Okay, say for example, the first time you're stretching the patient, you might encounter mild resistance. But once you're extending the extremities of your patient a full extent, you may encounter, okay, increasing resistance, or the patient may say, oh, it's getting harder, it's getting more difficult for me to do that. Okay, whereas class in your rigidity class, you would notice that there is uniform resistance to stretching. Okay, there is resistance to stretching, however, this is uniform. Then you have the term ataxia, dysarthria, and dysphagia. Okay, so class, try to review these terms. Okay, you have ataxia, dysarthria, and dysphagia. Are the possible complications from the motor deficits. So one is your orthostatic hypotension. Class, the orthostatic hypotension may already be a result of your paralysis and weakness. And then class, orthostatic hypotension may be also secondary to the fading autonomic nervous system. Recall class that you're in autonomic nervous system. There should be your sympathetic nervous system that should be working out to work out the blood pressure of the patient. However, in this case, the patient is still experiencing orthostatic hypotension. Class, this may also be secondary to the fluid loss of the patient. Now, our intervention for patients with orthostatic hypotension, if they are conscious, is for them to prevent or avoid abrupt position changes. Okay, because your orthostatic hypotension, obviously orthostatic, that's related to position. Okay, so class, transition between positions is recommended to be on a 5 to 10 minute interval. Okay, then you have your increased thrombus formation. that is secondary to immobility. Recall, class, that if your patient is immobile, there will be venous stasis. Once there is venous stasis, class, meaning the blood stays in the blood vessel, the blood, class, has a tendency to clot. And then this clot later on, or clot, will be forming a thrombus, clot or thrombus. And then there is a tendency for your clot to travel, okay, that is referred to as your emboli. Okay, so class, once your emboli would travel, you are exploring the risk for pulmonary embolism. You're also exploring the risk for myocardial infarction, also the possibility of ischemic stroke. Okay, for that reason, we don't want emboli to happen to our patient. Hence, we need to prevent thrombus or clot formation. One way for us to do that is to perform passive range of motion exercises if your patient is unconscious. Okay, whereas if your patient, class, is conscious and then your patient is able, you may allow your patient to do active range of motion exercises. Okay, now, one thing also that you can do is the application of your anti-embolic stockings. Class, your anti-embolic stockings is capable, okay, your anti-embolic stockings is capable of compressing the lower extremity in such a way that it would allow for venous return. Okay, it would facilitate venous return going towards the heart. Okay, hence preventing the formation of your thrombus. Other than that, to prevent your thrombus formation, we can administer your anticoagulants and your antiplatelet. However, you need to be careful if you are talking about a patient with hemorrhagic stroke. Okay? You are not supposed to administer anticoagulants and antiplatelets to somebody who is still recovering from hemorrhagic stroke, or else your patient's hemorrhagic stroke will come back. Okay, then you have your decreased cardiac output. Plus, the decrease in the cardiac output may be secondary to fluid imbalance. It may be secondary also to orthostatic hypotension. It may be secondary also, class, to the brainstem damage. Recall that your cardiac output is of two parts, or is the product of two components. That two components is your heart rate and then your stroke volume. Again, cardiac output is equal to heart rate times stroke volume, as we have discussed in cardiology. Now, class, you need to remember that the decrease of cardiac output may also indicate brainstem damage because your cardiac center, your respiratory center, is located in your medulla oblongata, which is part of your brainstem. It is the part supposedly that will be regulating your heart, class. Okay? Now, the decrease of cardiac output may be managed using your fluids. Okay, fluids. So you may give a lot of fluids. You may do blood transfusion to your patient. Okay? Now, impaired respiratory function. The impairment in respiratory function is of course brought about by paralysis. Okay, your patient, is unable to move. Okay, your patient may be unable also to cough. Okay, hence, class, your patient will be at risk for you have your stasis of the secretions. Okay, so class, that would mean that you are increasing the risk of the patient for pneumonia also. Now, because of this impaired respiratory function, class, the interventions done is with the use of your mechanical ventilation. Okay, mechanical ventilators. Then, class, we have your deep breathing exercises. Okay, if your patient is conscious. Respiratory etiquette also, class, if your patient is conscious. Okay, however, if unable to do so, class, you need to suction your patient accordingly. Okay, now, you need to be extra caution, okay, or you need to practice extra caution when you are doing your suctioning to a patient, class, with an intracranial problem. Okay, why? Class, an increase in the ICP could be aggravated by continuous suctioning. Okay, so class, your suctioning should be properly done in such a way that it would not increase the ICP of your patient. Hence, hyperoxygenate before suctioning. Okay, and then, class, you do not do your continuous suctioning, because that would increase again the ICP. Other than that, if you are exploring brainstem herniation, you are not supposed to do continuous suctioning. Okay, because, class, there is a possibility that you are already suctioning the brain tissues. Okay, if your patient is conscious, you may proceed with the use of your incentive spirometer. The succeeding motor deficits or complications would be discussed on the succeeding PowerPoint presentation. Thank you very much for your attention on this one.